back in the 50s and 60s, and they took all these little vaginal exams and they put them on a scattergram. They put them on a graph of dilation versus time. All right. And then they drew a line through the median, and that became the labor curve for first-time moms, we'll say. All right. So when you're now laboring, if you fall below the labor curve, they tell you you're not laboring fast enough. And therefore, we need to maybe rupture your membranes, or maybe we need to start synthetic oxytocin, or we need to get things moving, because obviously birth is on a timeline, because nature decided it's on a timeline. No, nature didn't, and I'm joking. But if you remember how the curve was made, just like with your due date, 50% of women are below the curve. So if you suddenly start to say that you're moving too slowly because you're below the curve, you're telling 50% of women they're moving too slowly in labor. Does anyone believe that that makes any sense at all?
You are listening to the Perspective Podcast. This is a space for you who are longing to come back home, deeper into your own center and your own truth. This is a space for you who are longing to deepen the relationship to yourself and to others. My name is Madeleine Mofjärd, and in this space I invite you to explore conversations that in different ways touch us upon the human experience. And I'm here to invite new perspectives. All right, so hi and welcome, Dr. Stuart Fischbein, to the Perspective Podcast.
Madeline, thank you for having me. It's always an honor to be on someone else's podcast. You know, Blyss and I do our own, and to speak to an audience that I might not otherwise be able to reach. Plus, you have my daughter's name and the same spelling, so
wow.
It's beautiful. I can just look at your name the whole time I'm talking here. Yeah.
It's meant to be. I also heard that it's probably the first Swedish podcast that you're a guest on, so that feels like a privilege to me to be the one bringing your voice to Sweden. It feels so good.
Well, I'm sure you reach across borders as well.
Yeah, of course, yeah. Specifically with these conversations that are in English, because normally I'm hosting in Swedish, but these conversations will of course reach other countries as well. But I'm excited today to dive into the topic of childbirth and how we can reclaim the power of childbirth as women, and get well informed regarding these kind of topics. And I'm curious, before we dive into this topic, to just check in with you, Stuart, today. How is the experience of being you today?
It's a tough day, quite frankly, for many reasons. I was woken up this morning by the sound of trucks doing construction at 6:30 in the morning. That stupid beeping backing up. I didn't think they could start that early. I thought there was an ordinance in my town, but that's a minor thing. Today is obviously the anniversary of 9/11. So that will always be a tough day.
Yeah.
And then, of course, yesterday was a very sad day. Excuse me.
Yeah.
I didn't know Charlie Kirk. I don't even know if you know who Charlie Kirk is. Okay. Well, your listeners can look him up. But he was assassinated yesterday while speaking to a university audience. And so it's a tough question. You got me, because I've been feeling really strong emotions, and they're all over the place. There's something going on in the world right now, more so than I've lived a long time, Madeline, and got my composure back. I've lived a long time, and I've seen a lot of tragedy in the world. I was alive when John Kennedy was shot, when the Challenger space shuttle blew up, when Robert Kennedy was shot, when Martin Luther King was shot. I hope your people in your country know who these people are.
Yeah.
And, there's been a lot of tragedies. I'm sure your country has been wrought with them as well. It just seems right now that there's a discord in the world that just seems greater than I can remember in quite some time.
Yeah.
So you asked that question, and you know what? If we could change the way women are treated in pregnancy and labor, and if we could change the way babies come into the world, we could do miracles. I think a lot of our thoughts and feelings and immune system and all that stuff begins in the womb, and we're not doing well. So, which is what we're here to talk about, hopefully today a little bit.
Exactly.
Right?
Yeah.
So, thanks for that question. How are you doing on this?
Thank you for giving the honest answer of how you're feeling. I'm doing good today. My heart is doing good. My body's doing good. I'm feeling strong, a bit tired, the pregnancy tiredness. I'm noticing my brain like sort of checking out a bit during these months of the pregnancy. But I'm doing good. My body's doing good. And I'm very excited. I'm thinking for the listeners who doesn't know about you and your work from before, is there anything you think is good for them to know about you as we dive into this conversation?
Yeah, I won't give a long bio because I really want to spend time talking to you, but I will just say that I was traditionally trained in the medical model of obstetrics. I went to the University of Minnesota Medical School. I did my residency in Southern California at a hospital that's fairly renowned in Southern California called Cedars-Sinai Medical Center. And in those years, we were affiliated with the Los Angeles County University of Southern California, what's called LA County USC Women's Hospital, which was in the early 80s when I was training, the busiest hospital in the United States in obstetrics, doing about 22,000 births a year, which is about 65 babies a day at that hospital. And I was there for 4 months every other day. So I got a lot of in-depth training. And I spent the next 24 years after my 4 years of residency in a hospital-based model in private practice. I was self-employed. I didn't work for anybody. Most doctors now, when they come out of residency or training, they generally get a job. And so they're a salaried employee as opposed to an independent contractor. And there are differences when you're a salaried employee than when you're personally responsible for your own clients. And I did that for 24 years. And then for circumstances which we may or may not get into today, I decided to leave the hospital. And I ended up doing another 12 and a half years of birthing in the home, working along midwives, collaborating with them in a beautiful relationship. I think the outcomes are probably best when midwives take care of normal pregnancy and doctors chime in when they're needed. Obstetricians are not experts in normal birthing. They really don't know much about it. They know a lot about pathology, and they're pretty good at that. But because they see birth as pathology, then every pregnant woman to them is a potential problem. And that's not how it should be yet. That's how obstetrics is framed. So getting back to myself, I'm a bit of a unicorn because I probably am one of the few physicians in the world who spent 28 years working in the hospital system and then 12 years in the home system. So I have experience in both. It's usually, one or the other for most practitioners. So that gives me that unique perspective that I would not have changed my way of practicing if I hadn't encountered midwives early in my career. And I would have been this automated, robotic OB/GYN who's still doing the same stupid stuff that I did when I was a resident and early in my training if I hadn't been woken up and been open to the idea that there are other ways to do things and not been so closed off to that and not been so have such cognitive dissonance that I can't see that there are multiple ways to do things. And what I think isn't really what matters.
Yeah.
It's what the woman thinks. And that system isn't taught to doctors in my country and most countries because many of the forces that influence how we practice medicine are out of our control. And they could be medical legal things. I don't know the legal system in Sweden, but the fear of litigation. It could be economics. Obviously, the more you do, the more money you can make, that sort of thing. It could be ego. Doctors have a big ego. They don't like to be told they're wrong. And it could be expediency. We do things because we have to do volume, and so we have to move things along. And you tell a woman she's not laboring fast enough as if there's a rule for that. And actually, they've created a rule, and maybe we'll get to that today, and I can tell you how stupid that is as well. So, yeah, that's what people should know about me, is that I have a perspective that's born of experience.
Yeah. And I heard you mention that you have actually, your words, been doing stupid things in your work in the early days. So what would you say, like what was
Oh
the
my God.
reason that you that you transitioned from the hospital-based practice to working more in the home space of birth? And what are some of those things that you might regret or like changed perspectives on?
Sure. Just an example of the stupidest things that I can recall are catching a baby with a woman laying on her back with her legs up in stirrups. Not a physiologic position. Position is for the convenience of the practitioner and not for the mother. It's not ideal for delivering babies, but that's how 95% probably of women deliver their babies in the world these days. Then thinking that this needs to be done in an operating room, thinking that it needs to be done with a sterile system where I'm washing off her bottom with betadine, which is that yellow-orange sterile solution, putting blue drapes on her legs, having the baby come out, immediately grabbing a cord clamp, clamping the cord immediately, as if we let it go too long, that would be a problem. This is what we were taught. Cutting the cord, showing this beautiful thing that this woman had just created, and then walking it over and setting it down in the warmer on the far end of the room. And I did that for years because that's what I was taught. And you kind of do what you're taught. That's, how we use our knife and fork at dinner is what we learned when we were kids. And only later did I learn that when I'm done eating, I lay my fork and knife together on the plate so that the waitress knows that it's time to come pick up my plate. I didn't learn that when I was a kid. So if I just was not open to learning new things, I would still be doing the same dumb things that I was doing back then. And that's just a very simple example for your listeners that's what I did. And why I changed was because I was always a curious kid. I was that annoying kid that would keep asking people why, and they would give an answer. I'd say, but why? And then they eventually get to the point where they're so exasperated with me, they would say something like, well, because I said so. I can remember my mother or father saying that. My mother mainly. My dad worked a lot, but my mother was our primary caregiver, and as most mothers are. And she would get exasperated with me, and she said, just do it. Don't ask why. And that never sat well with me. And when I started to see things differently, because the midwives would ask me questions. Why are you dressed in a full hazmat suit to catch a baby? Why are you wearing a poofy hat and a mask to catch a baby? It's not a sterile procedure. And then I would think about it. I go, you're right. And then they would explain to me about how dogs and horses and deer give birth. And it's like, yeah, they go off someplace where they're feeling safe, quiet, and unobserved, and they don't want to be hassled, and nobody takes away their food and water when they're in labor, and nobody bothers them when they're in labor. And if they are bothered, or if a predator approaches, they run away. And when I started practice, the cesarean section rate was barely in double digits. And now in many countries, it's 40, 50, 70, 80%. In basically 2 generations, we have seen the C-section rise 500, 600, 700% with no improvement in outcomes. So initially it was just the midwives that pushed me to do it, and then it became a self-fulfilling prophecy of me challenging pretty much everything, because as maybe we'll discuss later on, the way we should judge a system and how it's working is not based on intentions. It's based on outcomes. In pretty much every category of health, wellness, mental health, physical health, immune health, we're doing worse in the obstetrical world. And yet the people that run it keep doing more of it. And in my country, I think Einstein said this, doing something over and over again and expecting a different result is the definition of insanity. And so it's been very easy for me to be the person that I am now because I'm free to logically think and speak out. And part of that is because even when I was still working, I was independent. Yes, I had the Medical Board of California, and yes, I had the hospital rules and regs, but I was self-employed. I could decide how many patients an hour I wanted to see. I could decide how much time I'm going to spend with each one. I could decide whether I think breech for this woman is a good idea or an induction is necessary or not. I didn't have to follow some protocol or guideline, which if I didn't follow was going to get me in trouble with my boss. Mm. Doctors are heavily conflicted now. The medical system, nurses too. I mean, this applies to all people that work in the system. If they try to individualize their care and go against some policy, they can lose their job. We saw sort of that tyranny during the COVID era. I don't know what COVID was like in Sweden. I think you were the only smart country in the world, quite frankly, from what I
don't
read.
know how smart, but yeah, probably.
Well, I don't think you shut everything down like most other countries did.
Yeah.
And I don't think you forced vaccines on your people like most countries did. I don't know, did they?
Yeah, well, it wasn't forced, but it was highly recommended. And it's sort of the people not taking vaccines were shut out of families. And it was, there was a chaos for sure. But yeah, not as in the States, I think.
Right. I mean, in my country and in other countries, you couldn't go to work without it. You couldn't go to school without it. So they said you weren't forced to do it, but if you didn't do it, you couldn't live your life. Well, that's
it's the same thing.
Yeah. The truth is that subtle coercion is coercion. It doesn't matter if it's overt or subtle. It's coercion, and coercion, ethically in my profession is never, well, in any profession, but in my profession is never acceptable. All the organizations, your organization, the American College of OBGYN, the Royal College, all have very strong statements against the use of coercion, and yet every day in every doctor's office, in every hospital, coercion is being used to get people to funnel them down the path that the hospital or the doctor or the nurses want them to take, as opposed to backing off and respecting autonomy and understanding that we're not doing well. The prognostic uncertainty of the things we tell people is so bad that we should be more humble and say, listen, this is what I think we should do, but I understand you want to do it differently. Okay. I'm going to write in the chart and cover my butt, but I'm going to support you because that is my ethical obligation. That's been lost in the medicalized birth model. And I was lucky because I didn't plan on working with midwives. I was building a practice, and I was approached by local midwives in Southern California and asked if I would take their home birth transports. And I just looked at it, Madeline, as money. Every time I got a transport from one of them, I could bill several $1,000s and I'd make some money because I was trying to build a practice, pay off my debt, and, try to get some savings and stuff. Because, you finish your residency program generally when you're about 30 years old. So you haven't really been making any money while all your friends who went into business school and graduated when they were 22 have been making money for 8 years. And you haven't. So you need to do things. So I did it for mercenary reasons, and it turned out to be one of the luckiest decisions that ever happened for me. I'm the rare breed of what's called a happy gynecologist. Right? I would tell you that most of my obstetrical colleagues, and I don't know your country that well, but I would tell you that most obstetricians around the world are not happy. And how do I know they're not happy? Because happy people don't treat people badly. Happy people don't use coercion. Happy people don't roll their eyes when you say something they don't like. Happy people don't storm out of the room. Happy people don't threaten you or pull out the dead baby card on you and tell you, well, if you don't do what I say, your baby could die. Good people don't do that. So scared people do that. Unhappy people do that. That's my profession. And that's unfortunately the burden that women face nowadays when they become pregnant if they don't have other options or they don't know that there are other options, which I hope that your listeners will see that
Yeah,
there
and
are other options. They probably
yeah,
already know that because they're picking you as a podcast to listen to.
exactly, and that's also my intention with bringing you and different perspectives regarding pregnancy and childbirth on the show, to really help women and myself including to get more well informed and to make decisions that are aligned for them. I'm curious though to hear your perspective, because in my experience I feel like there's a lot of sort of myths or beliefs out there about around birth that tend to hold many women, but also like the system back. So what would you say are some of the most common myths about birth that you would like to just sort of bring down?
Well, one of the major myths is that pregnancies need management or need assistance. To grow a baby, to conceive a baby, grow a baby, and go into labor is all a primitive brain function. You don't you don't think about that. I mean, our brains think about all the wonderful things that might happen when we have that baby, when the baby's already riding a bicycle and, going to ballet class and scoring on the soccer field and all that stuff. We think about those things, but we don't have to think about conception, growing a baby, or going into labor. Those things, people need to understand that those are normal bodily functions, like breathing or digestion, that fortunately we don't have to think about. Can you imagine what life would be like if you had to remember to breathe every 4 seconds? You had to think about it, but you don't have to think about it because your primitive brain takes care of that. What happens when your cognitive brain or your higher brain function takes over is it screws up those primitive brain functions, which is why people who have to go to court or have to give a speech may hyperventilate. They may feel their heart pounding. They may get diarrhea. That's their cognitive brain overtaking their normal bodily functions. The same thing happens with pregnancy. Pregnancy is something that should be joyous. It's not a disease. The medical model looks at pregnancy as a potential problem that needs to be managed, and so they see everything through that prism. Whereas midwifery sees pregnancy as a normal function of the human body. They trust nature's design, and they're willing to accept uncertainty, that on occasion things will go awry, and that's where medical attention is necessary. The idea that you need to all births need to be in a hospital in case something goes wrong partly becomes a self-fulfilling prophecy, because things go wrong often iatrogenically because you're in the hospital. And therefore, then they need to intervene, and they think, oh my God, what would have happened if you'd been doing this at home? Never understanding that these things don't happen at home because you're not meddling with Mother Nature. And there's very simple ways to do that. If you take a similar cohort of women who are considered low risk, and you have them labor at home or in the hospital, you're going to find that pretty much in every outcome that matters, the home birth outcomes will be better. There'll be higher success rate for vaginal delivery, less instrumental delivery, less episiotomies, less lacerations, shorter labors, more maternal satisfaction, better breastfeeding rates, better bonding rates, less postpartum depression. I could go on. Okay. So, but this is ignored in the medical system. So one of the main things to overcome is the idea that something is broken the minute the sperm and egg come together. It's a joyous moment, and it should be celebrated as such. And you should be bathing your baby in joyous hormones like dopamine and oxytocin for 9 months rather than cortisol and adrenaline, which the medical model tends to instill, because again, they see fear, they see fear everywhere, and they project it onwards. Now, again, just so people listening understand that we are not talking universally about all nurses and all doctors and all midwives. There are good midwives, bad midwives, good doctors, bad doctors, but talking about the system. And sometimes good doctors are stuck in bad systems and they end up having to do things that they don't want to do. So I hope nobody takes this personally, but I think everyone should take it for what it's worth, that what I'm saying comes from years and years and years of experience and observing and partaking in both systems.
What would you say is the sort of the general view upon home births in America? Because here in Sweden, I think it's still looked upon as a danger and something really sort of alternative or like hippie wise to choose to give birth at home. And when sharing like plans on giving birth at home, I experience people getting afraid and like, how could you think that? And so I'm curious, how is that sort of climate around home birth in
It's the
America?
same here. The medical birth complex has done a great job over the last 100 years to again instill the idea that pregnancy needs management and could go wrong at any second, and therefore you need to be in the hospital. And we have generations of women in your country and my country who believe that. They, that's their experience. And if grandma and mom had C-sections, they don't want part of them. It's a personal ego thing. A lot of moms like to tell their daughters their story, and it becomes about mom rather than the daughter, and they have intergenerational trauma. And if you were to go on and have a beautiful home water birth, they may have to question the fact that their doctor told them they needed an induction and ended up with a C-section, and they don't want to do that. So there's a cultural wall to climb over, not just the medicalized birth model wall that you have to face every time. So yeah, in my country, 1 or 2% of women are giving birth at home. Yet there's an inordinate amount of emphasis from the medicalized obstetrical world about the ills of home birth. But I can tell them that we don't have a 35% C-section rate in the United States because 2% of women are giving birth at home. All you have to do is the math. And we don't have a doubling of the rate of newborn intensive care unit admissions in the last 15 years in my country because 1% of women are giving birth at home. But it's the Wizard. You know what the Wizard of Oz? You've seen the Wizard of Oz? Okay, I have so many cultural references that are American that I want to be sure. Yeah. But at the end of the Wizard of Oz, pay no attention to that man behind the curtain. Look at the fuzzy, shiny, flashy thing over here. So rather than face the idea that our medical birth model isn't working well, what do? They go after midwives who are doing home birthing. We're the low-hanging fruit, so it's very easy to say that. But they don't look at outcomes. And ultimately, they don't determine that it's a woman's choice of where to give birth. So rather than be open and honest about their counseling, they skew their counseling to funnel you down the path toward hospital birthing. Right.
And what do you think about that statement then? Because I've heard it so many times, the statement of like, but what if something goes wrong and you're giving birth at home? So what's your perspective on that statement?
I will tell you from somebody who's lived in both worlds that it's very, very rare for anything to go wrong suddenly at home when you're not meddling with a woman laboring. When you don't interrupt her, when you don't immobilize her, when you don't anesthetize her, when you don't starve her, when you don't hyperstimulate her with Pitocin or whatever you call it, Syntocin or whatever you call it in Europe. When you don't do those things, you rarely see the rapid deterioration of the baby's status that you see in the hospital where they suddenly think that the baby's heart rate drops and you need to do an emergency C-section and they get a good baby out of that. Then they say, thank God you were here. They don't have any self-awareness that they caused the problem in the first place. How can I say that? Because I've been at hundreds of home births. And on occasion, you can see something not going well. And you can say to the family quietly that, you take the dad out of the room and you say, if the things don't change in the next half hour, I think it's probably time to go in. In only rare cases do you ever have to call the ambulance. And on the rare cases where we did have to call an ambulance, almost all of that was postpartum. It was rarely for the baby or the mom intrapartum. It was for bleeding, hemorrhaging postpartum, or a baby needing respiratory assistance more than we can supply at home. And again, all you have to do is read the studies. There's a huge study out of Europe that looked at over 500,000 home births, I believe. I think it was multiple countries involved. Uh, and again, as I said, in every outcome, the results were better for babies born at home when properly selected and with a skilled attendant. Problem with many studies that people look at is there's no control in what protocol were they managed by? What was the skill of the level of the person managing them? What was their prenatal care like? You can't control for those things. All they look at is, certain outcomes. And almost every paper on birth looks at only neonatal death and neonatal morbidity, occasional maternal morbidity, occasionally C-section rate. But they don't look at maternal satisfaction rate. They don't look at how did the mom do down in the future with her other babies. They don't look at how did that baby do at 6 months of age or when it was 5 years old. How did that mom do in subsequent pregnancies because she had a C-section for breech and then she ended up rupturing her uterus in a subsequent pregnancy or having a placental implantation problem called a CRETA because of the C-section that she had, which they told her was necessary for a breech, but really probably wasn't in 80 or 90% of the time. But they'll tell them that. But those things are never measured on a paper on outcomes. It's not a simple equation of this or that. It's very complex and intertwined. And if you don't know these things, and if the only thing that matters is getting a live baby in the bassinet, then you can understand, again, where they're coming from. But there's so much more. Our immune systems begin in the womb. And when we're taken out by surgical birth, or we're taken out after mom getting antibiotics over and over again, that affects our immune system possibly for the rest of our life. That's not in any research paper on outcomes for home versus hospital birthing. They don't look at that. They don't look at the mom's postpartum depression rate in hospital versus home birthing. I can tell you from experience that, again, do I need a study to tell me what common sense would dictate? No, I don't. I know that some people do, and okay, fine, but some studies are impossible to do.
Yeah, right, because there aren't even many studies made on home birth, right?
No, no, because generally midwives are not academic. People that work in medical schools and in residency programs and academic hospitals, there's the old adage that says, if you're in academia, you need to publish or you perish. So they're always doing studies on some of the most ridiculous things. Like they come out with things like, oh, delayed cord clamping. Oh, 1 minute, 60 seconds. That's what you should do. Does anyone listening think that that's scientific? Does nature work? I have this thing called my Dr. Stu's exact number rule. And it tells you how if you just break it down, people don't think like this. This is my brain. I have too much time on my hands. But why age 35? Why 24 hours of ruptured membranes? Why 40 weeks? Why 1 minute of delayed cord clamping? Where do these numbers come from? Why not 57 seconds? Why not a minute 22? These things are fake numbers, yet they come up with them, put them out there. They become benchmarks for quality, and then hospital risk managers and administrations adopt them as rules. I'd like to tell your listeners that, yeah, maybe home birth isn't for you, but hospital birth, the hospital works for you. You're the consumer. You're the employer. You're employing them. You get to decide how you're going to be treated. You get to decide whether you want no cord clamping at all. You get to decide whether you want to eat in labor. If the hospital has a rule that says you can't do that, tell them to go stuff it. They can't force you to do that. You can abdicate your autonomy when you come in with a broken arm, or a ruptured appendix because you need emergency care. But That's not what most women coming to the hospital are coming there because they've been told it's safer or because that's what their insurance will pay for. And that's where mom had her baby, and that's where my sister had her babies, and I'm just going to go to the hospital and I'm going to use the doctor who's been doing my pap smear for a decade, and I don't know anything about their obstetrical skills or their philosophy. I'm just going to go there. And by the way, the doctor that I like may not even be on call, and I'll get some stranger, and that's okay. It's not okay. You know, Madeline, you probably heard the wedding analogy. People in the birth world have heard the wedding analogy, but most likely in traditional women's life, a wedding and the birth of their children are probably the two most sacred and memorable events. And this is not putting down other achievements you might have, like graduating law school or getting a gold medal in something or whatever. Those obviously are major things. But traditionally, your wedding and your birth of your children are your big events. And for your wedding, you plan everything. And you spend a lot of money, usually. And you pick the dresses and you pick the food and you pick the venue and you pick the people you want to come to your wedding and you pick the invitations. And I always say this, for God's sakes, you pick the color of the napkins for your wedding. But for your birth, you abdicate everything to a third party. You know, what does my socialized healthcare system say? What hospital can I go to? Which doctors can I use? I'm going to be taken care of by strangers. I'm going to have people, you know, no one would allow someone to do that for your wedding. They wouldn't let you, they wouldn't pick the venue. You wouldn't let third party invite people to your wedding you don't like. If you are allergic to something on dinner or you don't like fish, you wouldn't have the fish for dinner. You'd have the steak or the chicken or, you know, whatever you'd have, but you wouldn't let someone else decide on the menu. When you go to the hospital, you abdicate all those things. And we do that simply out of culture and habit, not because it makes any medical sense whatsoever. We've been brainwashed to believe it makes medical sense. And for a small percentage of women, it does. Mm. Maybe 10% of women need medical attention when they're giving birth. The other 90% don't. And maybe a small percentage of those will as labor goes on. But not for 9 months of pregnancy where you're being bathed in anxiety and fear and having unnecessary testing, which has poor predictive value in the first place, and yet they're doing it on you. And that leads to some false diagnosis like your fluid looks low around your baby. I know I'm having flight of ideas here, so forgive me for just going off on a tangent.
No, go on.
But, you know, and then they make a mountain out of a molehill. And then they talk about, well, you know, we don't know what's going on here, so I think we should induce your labor. And induction leads to all kinds of complications, and yet they say it's for your own good. They don't tell you the downsides of induction and how it can lead to interventions and C-sections and more likely fetal distress. Again, because I've lived in both worlds, I know that newborn intensive care units in my country often have many 7 and 8 pound babies in them who came inside their mother to the hospital in perfectly healthy condition. And somehow, because of what happened in the hospital, they ended up in the newborn intensive care unit. And that's become normalized now. It shouldn't be normalized.
And then
we shouldn't accept the fact that
get to hear that you're lucky that you were in the hospital, right? Then that's the sort of statement that comes after that.
But they don't even realize what they're doing. And part of me is very cynical and believes that not the individual doctors or nurses, but the hospital is very happy when a baby goes to the NICU. Because NICU is a moneymaker for hospitals. And hospitals have a different ethical perception of birth than you and I do. Hospital's job, its fiduciary duty, is to keep its doors open. It's to survive financially so it can pay its overhead and it can make a profit for its shareholders or for the employees that work there. They have to pay their salaries. How do you do that if you don't bill for things, if you don't do things? You know, that's why part of the reason I think the vilification of home birth is such that hospitals can't bill for something when you birth at home. There's no charge for not giving Pitocin. There's no charge for not starting an IV, not drawing blood work. Imagine if the hospitals got paid more for vaginal birth than they did for cesarean. Imagine if your hospitals got paid more if the cesarean section rate in that hospital was under 20%. And the government said, or the insurance company said, if your rate's under 20%, we'll pay you this much more per birth. And if you're over 30%, you're going to get this much less per birth. You'd suddenly find C-section rates dropping. And some people will say, well, that's coercive. Yeah, well, it is. But that's basic economics. Anybody who's taken economics knows that if you want more of something, you subsidize it. And if you want less of something, you tax it. And that's the truth. So if you want to lower the C-section rate, you could do that tomorrow. So ask yourself why they don't do that.
And that's definitely a shift in perspective, the way you're putting it. Like, it could be done in such a sort of easy way, but there's also interesting, because something that I think I'm hearing a lot is like women asking, when talking about home birth or when talking about saying no to certain interventions if you choose to give birth in a hospital system. I hear this statement of like, but are you allowed to do that? Like, can you actually do that? Do you have anything to say about that sort of belief that many women have, and not only women, but this belief that we are not even allowed to be in charge of our own bodies and our own choices regarding birth?
They've done a great job of marketing and propaganda, and something called mass formation. And mass formation, I read a book in 2022 written about the COVID thing by a guy named Matthias Desmet, and it's called The Psychology of Totalitarianism. And it kind of explains how, as you said earlier, people that your kids used to play with on the block were no longer allowed to play with other people's children. Or your neighbors were calling the local authorities saying you have too many people in your backyard. And people that you used to be your friends are no longer your friends. You were no longer invited to your holidays at your family, or you weren't allowed to see your grandchildren because you chose not to get vaccinated. How does that happen? How does that cult-like behavior overcome the bonds that you had? And it explains that. So we as consumers, or women, pregnant women, have been culturally indoctrinated to believe that they need all these interventions. And so when the hospital tells you that, you tend to just fall in line, and they say that you're not allowed to do that. Okay. You have to understand that you need to break free of the cult. And you need to say, excuse me, even if I was having a heart attack, I have the right to refuse therapy. You're telling me that I'm having my baby and I have to wear those belts on me? No, I do not. You're telling me that I can only have a popsicle or clear liquids? No. My husband's brought me some great chicken broth, and I've got some applesauce and some yogurt, and I'm going to have that in labor, and you're not going to stop me. Now, I'm not telling your listeners to be confrontational with these people. And the key is to not wait until you're in labor to find out what's allowed and not allowed. There's a famous saying that says, you're not allowed to not allow me. And that's how people should respond. But you should do these things way ahead of time. When you move to a new community, Madeline, or when when you're thinking about having kids, you check out that community, you check out the schools, you check out the churches, you check out where the shopping center is, you check out what are the taxes in my city or town. You check all those things out. But you don't check out your local hospital. And you should. Before you're pregnant or early in your pregnancy, go to your hospital, go up to labor and delivery, speak to some of the nurses there, ask them these questions, ask them about what happens if I come in labor and I want to eat, or what happens if I break my bag of waters and I'm not in contracting yet? Do I have to get induced right away? Ask these questions of your obstetrician, ask these questions of your hospital, do it ahead of time. so that you know what the policies are, so that you can know and you can come up with a birth plan between you and your partner, maybe your doula and anyone else, your family, and come up with a birth plan that says, this one I'll accept. Okay, I'll let you start an IV, even though I don't think I need one, but I'm not doing blood work, or I'm not going to be monitored. I'm not going to lay on my back in bed. I'm not going to do those things. And I'm going to bring my own food and going to bring my own lighting, and I'm bringing my playlist. And I'm going to have my husband and my sister and my doula all in the room. And if they don't want to go along with that, then maybe that's not the hospital for you. And maybe you might have to drive to the next town to find another hospital that might be more accommodating to what you want. But if you don't check these things out ahead of time, if you just rely on what everybody else does in your insurance card or your government card or whatever, and you go into labor and suddenly you find out that, oh, you can only have one visitor. So your sister and your husband need to switch off. I mean, is that stupid, or is that just stupid? Why are these policies put in place? They're not put in place because they're better for health outcomes. They're put in place because they're better for the hospital or the institution, or what they perceive as being better or easier to manage or control. They may tell you you can't video. It's like, go F yourself. It's my birth. Okay, yeah, I'm not going to video my knee surgery. You don't want me to video that? I'll be asleep anyway, I don't care. But this is a life event for me. Would you ever have someone tell you you can't video your wedding? Now, you may video your wedding and then never look at it again, like mine, which sits in the closet. But yeah, you have it because you want it. This is a joyous occasion. Again, we need to change the way we think about this event. It's not a medical event, except when it finally becomes one. Most of the time, it's not. This is what your body is designed to do. This is what every mammal on the planet is designed to do. And rarely is intervention necessary. You have a lot of people in Sweden who probably do farming, cows and sheep and things like that. I mean, those things are an investment for them, but they wake up in the morning, there's a new calf. They didn't have to sit there with bright lights on and stare at the cow all night long. You don't see the other cows standing around staring at the cow that's in labor. They actually protect the space. It's very sacred. The cow needs to be left alone. It needs to be quiet. It needs to be unobserved. It needs to feel secure and safe. And if it doesn't, then labor will stop. That mammal will get up, will go someplace else. And only when it feels safe will labor then return. This way, nature ensures the best chance of survival. We have taken that normal mammalian thing and just obliterated it. Everything we do, from the moment you drive to the hospital in your car till the moment you put your baby in the car seat to drive home, is antithetical to the way nature designed it. And nature didn't design things because it's a fool. Nature designed things over thousands and thousands, if not hundreds of thousands of years, to come out with a system that's nearly perfect. And man has the hubris to believe that we can make it better, yet never looking at their outcomes to find out that, you know what, pretty much in every outcome since the 70s, I'm not talking about in the years before we knew how to wash our hands between cadaver lab and catching a baby, and we didn't have gloves, and we didn't understand germ theory, and we didn't have antibiotics and all that. But in the last 50 years, every outcome has probably gotten worse. Not because of the health health interventions, but despite them. So I know that this is going to be shocking and upsetting for some people. And some people right now, their stomach's in a knot and they're feeling cognitive dissonance because it makes them very uncomfortable.
Maybe they've pressed pause already on this conversation.
And that's okay. But they maybe had their first birth, and maybe they were told that their baby was big, and they were brought in for an induction, and the whole cascade of interventions happened, and ended up with a C-section. And they don't really want to know that maybe what they were told was all gaslighting, and their doctor was wrong. And they were led down a path and were deprived of an experience. It's a very hard thing to believe. I think part of the reason that my doctor colleagues don't wake up is because of cognitive dissonance. If you've been doing unnecessary cesarean sections for 20 years, how do you reconcile that? How did suddenly say, I'm sorry, I know that I did unnecessary cesarean sections and unnecessary inductions early in my career. I know that. And I freely admit it, and I feel bad about that. But I don't hold it against myself because it's all I knew.
When you talk
But my
about
colleagues who go ahead.
no, when you talk about cesarean sections being unnecessary and that you've made unnecessary interventions in that way, what could be something that leads up to those cesarean sections happening when they aren't really necessary? Like why? Yeah, what's
Oh my
leading
God,
the build up?
that's okay. Well, that's a great topic. Just let me give you some data. I'm not a big fan of the World Health Organization. I think they've done a lot of bad things. Uh, but even they believe that the C-section rate should be somewhere between 10 and 15%. And they have looked at that and they said that a C-section rate of about 10 to 15% will optimize outcomes, but anything beyond that does not improve outcomes, actually makes them worse. Yet there's no country in the world that has a 10 or 15% C-section rate. Every country has higher than that. I don't know what it is in Sweden, but I'm sure it's in the 30s, 30 or 40% probably in Sweden. So let's just say it should be 15%. And let's just say it's 30%. Well, it's not difficult math to tell you that half of all C-sections being done are unnecessary according to the World Health Organization. And history, because 30 years ago, your C-section rate was half of what it is now. And your outcomes are not any better. So we've done hundreds of thousands of unnecessary C-sections over the last 30 or 40 years with no evidence of improvement in outcomes and actually evidence of non-benefit. What are some of the indications for an unnecessary cesarean section? Going past 40 weeks. 40 weeks this is a very simple math problem too. Everybody probably listening knows what a bell-shaped curve is, right? You know what a bell curve is?
I don't think so. Yeah.
Okay, a bell curve is a curve where you have two standard deviations below the mean, two standard deviations above the mean. It looks like it goes up and down, and the peak is the median. So test scores are on a bell-shaped curve. IQ is on a bell-shaped curve. Traffic patterns are on a bell-shaped curve. All right. 40 weeks is the peak of a sort of a flat bell-shaped curve. If doctors tell you that going past your due date puts you at greater risk, what they're telling 50% of women is that they are at greater risk because 50% of women are on the other side of the median, which is 40 weeks. That makes sense?
Yeah.
So does it make sense to anyone listening that 50% of women are going overdue and that's wrong? No, it's not. But we've been told to believe that. I got dozens of these examples, but we'll stick with that one. So going beyond your due date is not a reason to induce. Having an unnecessary ultrasound is going to possibly lead to an unnecessary induction because they're going to find something. Oh, your baby's looking a little small, or your baby's looking a little big, or the fluid around the baby is a little bit low. And they're going to tell you that, that's dangerous, or your placenta is looking a little bit calcified. All those things are variations of normal. And none of them are a reason to induce in and of themselves. If you have a baby that's truly growth restricted and is not growing well, and the blood supply to that baby is compromised, that baby needs to be delivered. Right? If you have a woman who's got poorly controlled diabetes and her blood sugar's all over the place, that baby should probably come out before term because the risk of stillbirth begins to rise. And again, the risk of stillbirth is often used as a club to get people to do what you want them to do. And they'll often use something called relative risk. And relative risk, I will tell listeners, is meaningless if you don't know what the denominator is. What you need to know is what's actual risk. For instance, let me give you an example. How many births are in the, how many people live in Sweden? What's the population of Sweden? Do you know?
You shouldn't ask me those kind of questions. Actually, I do
Oh.
not know the number.
All right. Well, let's just say it's 20 million people. All right. Or I'll use California because California is an example that I know really well. California has about 40 million people. Has a little bit less now because people are leaving, but it has about 40 million people. So say something happened last year one time. The incidence in California would be 1 in 40 million, which is essentially zero. And say this year it happened 10 times. Somebody advocating for funding for prevention of this thing that happened 10 times will say, look there's been a tenfold increase in this problem happening. And that sounds awful. But it's still 1 in 4 million, which is still zero. So you can see the difference between relative risk, a tenfold increase, versus actual risk, which is essentially 1 in 4 million versus 1 in 40 million, which is basically the same number. It's zero. So when you use relative risk counseling, you can get people to do things that you don't want to do. So anybody, when you're counseled about something like stillbirth, and they tell you, well, the risk will double if we wait another 2 weeks. Well, okay, but what's the actual risk? Because doubling of a very small number is still a very small number. So these things, this is coercion, by the way. This is that subtle form of coercion that doctors who are fearful will lay on you to get you to do. And if you're not aware, you'll fall for this because the thing you want most in life is to have your baby come out healthy. And if somebody tells you that it's dangerous, you're not going to ask them, well, can you define what danger means? You're just going to hear the word dangerous. And that's what happens. Other reasons for unnecessary cesarean section, diagnosis of cholestasis of pregnancy. I mean, excuse me, unnecessary cesarean is what we were talking about, not induction, but in cesarean. Suspected big baby, not a reason to do it. I could tell you the number of reasons to actually do a elective cesarean section are few. And that's probably easier than the ones not to do it. And that would be something like placenta previa, true growth restriction. Sometimes it's for social reasons. Like an induction or a cesarean section, you might schedule it because the baby has something wrong with its heart. And you want to deliver that baby at an institution at a time when the heart team is available. Those are rare and few far between. But I can tell you that, again, if I know that I said at least half of all C-sections are unnecessary. I think it's much higher than that. And a lot of them are iatrogenic because they're caused because people are told they needed to be induced. And then the induction and the baby's not ready and mom's not ready and it doesn't go well and they end up in distress or not going fast enough or whatever. And so they end up with a cesarean section and everybody thinks they did a good job.
I've heard someone say that induction is the greatest pandemic. Do you agree with that?
I'd never heard that before. Yeah, the greatest pandemic? Yeah, it's a really interesting thought. And it's not a pandemic because a pandemic would be something I think that nature does. I mean, I hate to steal a phrase from my colleague Mickey Willis, but it's more of a plandemic. Right. Yeah, the use of the induction is way, way, way overused. I mean, 30+% of women now are being induced. In a study out of England and a study in the United States, the CDC data says that. Does anyone listening believe that 1/3 of women need to be induced? In 1990, the induction rate in my country was under 10%. So what's happened in 35 years that means that the induction rate needs to triple? And if it's tripling, shouldn't the outcomes be better? But they're not. So, go ahead.
What would be actual reasons then to get induced? Like what would be correct reasons to do it?
Preeclampsia.
What is
poorly controlled
preeclampsia? That's
Preeclampsia is when usually toward the end of pregnancy, sometimes in the second trimester, blood pressure will rise, you might get swollen, your kidneys start to spill protein in your urine. It can progress to serious things like growth restriction, liver abnormalities, blood clot, platelet abnormalities, stroke, seizures, which becomes eclampsia then. Eclampsia is whatever, I don't know if it's Latin or whatever, but it means seizure. And so preeclampsia means you're on the way to getting seizures. And the only treatment for that really is delivery, but it's not always an emergency that you need to deliver right away. Depends on many other factors like gestational age. How's that baby doing inside? Can you buy more time for that baby in utero? Because if you take that baby out at 34, 35 weeks, you probably are going to spend 2-3 weeks with that baby in the newborn intensive care unit. Again, separated from mom, separated from dad, possibly getting IVs, probably getting antibiotics, which is going to screw up its gut and microbiome, and possibly getting formula instead of breastfeeding, and all those things that can happen. And again, if you think labor and delivery units are on autopilot with rules, wait till you get a baby in the newborn intensive care unit and try to deal with all their ridiculous rules. Again, this is a broad statement, but the medical system works on algorithms. And there's very little room for individualization in the system as it exists today, which is, again, is part of the reason we're seeing all these rising problems. Because to assume that two women are the same is an error in ethical judgment. There's a basic tenet of ethics that says, given the same information, it's not reasonable to expect two women or two patients to come to the same conclusion. Yet in the medicalized birth model, every woman who's diabetic needs this test, this test, this test, this induction, this on this date. Every set of twins, if they're non-identical fraternal twins, this is how we manage your pregnancy. This is how, when we tell you need to be induced. If your baby isn't head down, we need to do a C-section. This is a standard protocol. But there's no data to support that. It's purely skewed interpretation of the data and ignoring contrary data. And when there's data to suggest that there are different ways of doing things, the decision belongs to the mentally capable woman, not to the institution, not to your OB, not to your insurance company. They are not the ones ethically who are supposed to make those decisions, yet we have abdicated that responsibility to them because we're sheep. Pregnant women need to become shepherd. They need to take control of their bodies and their lives and understand that by doing so, you're not hurting your pregnancy. Educate yourself. The best way to overcome fear is knowledge, because you always fear what you don't understand. And fear is the easiest way to manipulate somebody. So if they can get you being nervous at your first prenatal visit by telling you, Madeline, you're over 35, and so you're really a geriatric pregnancy, and so we're going to need to do these things as you get further along, and probably some extra testing. And so now they've just planted seeds of doubt. If you've ever watched the movie Inception, some of your listeners probably have.
Yeah.
Once you plant an idea in someone's mind, you can't get rid of it. Like the example they use on the movie is they say, well, don't think about elephants. Everyone now is thinking about elephants. You can't get it out. So if you plant something early on in a young girl's life that she doesn't understand her body, she doesn't understand her menstrual cycle. Her menstrual cycle is something to be grossed out by, and boys get, ooh, she's on the rag. Don't talk to her right now. And this is the kind of thing that they're taught in middle school and high school. And then they're not taught about their bodies as being these wondrous, miraculous, I don't even know what word to use. Creations, where you can take one cell, a half a cell actually, join it with another half a cell, grow a human life inside of you, give birth to that human life, feed that human life, that, yeah, that's what they need to be taught.
Mm.
And that the menstrual cycle is all a part of that. We never used to have due dates. We never used to. I mean, I get a lot of this, what I'm telling you, from my midwife colleagues, including my co-host Blyss. But prior to the modern era, we didn't know when you were due. You basically counted moons. And so no emphasis was put on September 27th is Madeline's due date. So I'm going to call her on the 28th and find out why her doctor hasn't induced her yet. And then everybody's going to write it down on their calendar and they're going to call you. Well, my doctor says it's dangerous to go past your due date. And my doctor says this, and and this is what I did, and this is what happened to me when I didn't listen to my doctor. And everybody's going to tell a story.
Yeah.
And you're going to take that woman who's supposed to be having the most joyous experience of her life. Yeah, she doesn't feel good. She's short of breath a little bit, and she feels fat, and she can't eat as much as she used to, and she feels nauseous, and her bladder and bowel aren't working as well as they used to. But she otherwise is feeling miraculous, and taking that away from her and substituting fear. And that needs to stop. And it stops with people being educated by listening to your beautiful Perspective podcast.
Mm. Talking about this idea of getting well informed and educating yourself, to me, my experience is that there's a lack of information that we get from the sort of the medical system, at least here in Sweden. Even though it's midwife based and there is information, but I think the information is very sort of one-sided. So voices like you are so needed to really share these perspectives that help women get the right information. To sort of sum this conversation up, would you say is the information and the education that women have the right to really get a grip on before getting birth, and that should be important for women to really get to sum it up in a way?
Yeah, you asked very provocative questions, and this is a really good question because in the day of instant information, and we know that much of what we've been told about many medical things has been wrong. It's hard to know where to get reliable information. So what I can tell people is research in medicine right now is very compromised. Research is paid for by big medicine and big pharma. And in order to get something published in one of the major journals, the British Journal, the Lancet, the New England Journal, you have to meet the criteria of the editors. And the journals are completely sponsored by pharma. And big medicine. So it's very difficult to get a contrary opinion published these days. Plus, there's great risk to people who are publishing contrary to the narrative data, because we saw during COVID, we saw physicians lose their licenses. We saw people kicked off staff. We saw people have their board certification taken away simply because they spoke a different thought, which turned out to be true, by the way, because they went against the narrative. So bravery is not something that's in a common commodity these days. We don't see a whole lot of bravery. So where do you get your information from? Well, you have to find sources that you trust. And how do you do that? It's experience. It's just listening and what resonates with you. Trust your inner instincts. If something sounds fishy, as we like to say, it's probably not true. If something seems to resonate with you, then that's probably where you should go. And I'm not saying that I'm going to resonate with all of your listeners. Some people are going to look at me and they think that I'm a fool. And that's okay. I am speaking from my experience, but I don't expect everyone to listen to what I'm saying. But also try to find people who are not motivated necessarily by financial gain or compromised uh, by their sponsorship. Their research is sponsored by Pfizer, or the research is sponsored by our National Institute of Health. Those people are compromised. They know if they publish a finding that goes against the narrative, they're going to lose their grants. They're going to lose their funding. So just because something is published in a journal, that doesn't make it true. And what really isn't true is when you see something in one of your newspapers, because science is not propagated by headline, right? Science doesn't propagate by press release. You might find a very interesting thing in the news and you'll say, wow, that sounds really interesting. And so you'll say, well, I'm going to do that. I'm going to try this new vitamin, or I'm going to try this new tool for my weed whacker because you see an ad for your weed whacker. Well, that's an ad. And newspapers are just, even news stories today are now sponsored content for the most part. So you have to realize that, and you have to think for a second, wait a minute, am I being gaslit here? And I'm going to need to look into it more before I follow what they're telling me. And then you look into it and you look at a paper that they're quoting in the newspaper, the research paper, and you find out that the material and methods section tells you that this was a really bad paper. That was adopted simply because it supported the narrative. Like there's a trial that came out in 2019 called the ARRIVE trial, which said it's safer and better for women to have their babies induced at 39 weeks. I mean, does anybody really believe that? Again, medicine thinking they know more than Mother Nature. And when in the modern era has that worked out for us? Yeah, let's genetically modify our food. Let's spray aluminum and barium into our atmosphere. Let's put glyphosate on all our crops. Yeah, that's all working out real well for us, isn't it? I mean, I could just go on and on and on. 5G towers next to your house. Another thing, by the way, when you're pregnant, I'm going off on a tangent here, but when you're pregnant, you got to be really careful about EMR. I think it's electromagnetic resonance. Yeah, EMR, I think it's called, or EMFs. No, EMFs. What is EMR? Electronic medical record. So that's electronic medical record. So I mean EMF, electromagnetic frequencies. You should be careful. And if you're pregnant and you live in a house that's right next to a 5G tower, you got to get a meter and check it out in your house. Don't don't wear your cell phone next to your belly. You know, maybe turn off Alexa for 9 months if you have that in your house. I don't know what you call it in Sweden, but
put her to sleep.
What do you call it?
Put her to sleep, Alexa. To put her to sleep for 9 months.
Put Alexa, turn yourself off.
Yeah.
No, just check these things out. Maybe find where the baby's going to be sleeping if it's not in your bed. Maybe make sure you get a meter and check your house and find out where the least amount of EMF is. Do those sorts of things. Protect yourself because, again, the medical world and the business world, they don't care. They're out there to sell stuff, and they don't care about your health. And of course, the cynical person would say, yeah, the more unhealthy you are, the more stuff they can sell. So what's the incentive of these companies and these corporations and stuff to keep you healthy? So I find good sources on a I don't know if you have Substack in Sweden.
Yeah, it exists.
Substack is where people are independently write and you subscribe to them. You can get their articles for free, but they $50-$70 a year. And you subscribe to them, and there are certain authors that I follow because I think that they're not motivated. They're on Substack because they don't want to work for a major news corporation or a major journal because they know that they're corrupted. So they can freely publish because it's self-publishing on Substack. So there's good information there. And then, seek different opinions. Don't just settle. If you go see a midwife and the midwife tells you something and it resonates with you, that's good. But maybe go see an OB and bounce it off them and see what they say. And then you can weigh the two in between and you can figure it out. You have to do the work. Think of it like a life event and not this medical problem. It's a life event and you plan ahead for it. You know, your child's graduation from high school. You're going to plan a party. You're not going to decide last minute, oh, today's graduation. Oh, I'm going to call up the neighbors and see if they'll come over. No, you plan ahead because it means something to you. Make this a meaningful event. Make this a joyous event. Understand that what you've been taught and what's been culturally passed down for the last 3, 4 generations, in so many instances is inaccurate. And it's wrong and it's self-serving for the system and not for the individual woman. Algorithms do not help the individual woman. Algorithms make it easier for the system to function. Find a doctor who's willing to spend time with you, who looks you in the eye, makes eye contact, isn't sitting there typing into their EMR, their electronic medical records, and gives you more than 8 minutes per visit. I mean, that's why the midwifery model is so great, because the prenatal visits are an hour long generally with midwives. And midwives know firsthand that they're not going to get rich. And they have low overhead, so they don't need to do volume. The whole system of medical is self-perpetuating. Because overhead is expensive, they need to do volume. And when you do volume, you can't give the kind of attention that you give. And then you have outcomes that maybe not be as good. And then you have to have algorithms and protocols to try to regulate those poor outcomes. And then you end up, it's just this terrible Mobius strip that you can never get off when you're in that. And I would tell any medical people listening that if you feel like any of this resonated with you, maybe you need to make a change in your life. If you're the unhappy gynecologist or you're the overworked midwife in some medical system, maybe decide to take a pay cut for a little while anyway, and go off and and if it's possible in your country, to go into private practice. You know, don't take insurance. Ask people to pay cash. If you build it, they will come. And women are dying for something like this. Women, and if women start making the demand for alternatives, then the demand will show up. And that's what we need to do. And nothing I say is going to cause some major hospital to change what they're doing. But if the women start coming in at their first prenatal visit and refusing to have their blood pressure checked or have any blood drawn, but just say, listen, I just want to talk to you. I want to know what happens if my baby's breached. Do you assist breech delivery? Oh, you don't? Why not? Or, you know, if my waters breaks and I'm not in labor, what's your recommendation? Oh, I have to deliver within 18 hours? Can you show me data on that? Why? If I break my bag of waters at 26 weeks, which is in your 5th or 6th month, you put me in the hospital and you keep me there for a month or 2. Yet if I break my bag of waters at term, the baby has to be out in 18 hours? Explain that to me, please. Oh, I got, again, the illogic of so many things that I used to do and that are still being done is incredible. One last thing I'll just want to tell people about is the labor curve. Because this one really got to me. I just kind of realized this in the last couple of years. Never really thought about it because I thought it was stupid, but I never really thought why it's stupid. But there's a labor curve. It's often called the Friedman curve. And there's one for first-time moms and there's one for multips. And the first-time moms are supposed to move beyond a certain 4 centimeters or now 6 centimeters, whatever. You're supposed to move a certain number of centimeters per hour. And the only way you're going to know that is to do vaginal exams. And I'm going to tell women right now that vaginal exams are not necessary for 95% of pregnant women. How many, as Blyss likes to say, how many tigers have been checked at 7 centimeters? Not very many.
Yeah.
Right? So you're not going to do that to another mammal, but you need to do it to a human because you need to know if you're progressing. So that's what they did back in the 50s and 60s, and they took all these little vaginal exams and they put them on a scattergram. They put them on a graph of dilation versus time. All right. And then they drew a line through the median. And that became the labor curve for first-time moms, we'll say. All right. So when you're now laboring, if you fall below the labor curve, they tell you you're not laboring fast enough. And therefore, we need to maybe rupture your membranes, or maybe we need to start synthetic oxytocin, or we need to get things moving, because obviously birth is on a timeline, because nature decided it's on a timeline. No, nature didn't, and I'm joking. But if you remember how the curve was made, just like with your due date, 50% of women are below the curve. So if you suddenly start to say that you're moving too slowly because you're below the curve, you're telling 50% of women they're moving too slowly in labor. Does anyone believe that that makes any sense at all? Yet I can tell you your average obstetrician or nurse has not even thought about it that way. But how did they come up with the labor curve? It wasn't the 10th percentile of labor progression. It was the median. It was the 50th percentile, which means that, again, half of all women are laboring slower than that, and they're telling them that it's abnormal. How can something that affects half of women be labeled abnormal? Where's the logic? Where's the thinking?
Yeah.
Was there any thinking? I don't know. The more I learn, the more I think that the people who thought this stuff up were out of their minds.
I also think it's so interesting, like the use of words, how we use words to also impact and put fear into women, like the way you're describing it, like then you're laboring too slow, like it's not working because you're too slow, and the kind of stress that puts into women, I can only imagine. And here in Sweden, I don't know if there's a word for this in English, but in Sweden we have a word that describes when the contraction starts to slow down. And you call the woman that it's actually phrased like she is now like weak of contractions or something. And in Swedish, the word, it sounds really diminishing and like it puts her into a really weak spot, the woman, when the contractions.
What's the word?
It's called verksvag in Swedish. So verk is contraction and svag is weak. But then you also phrase it as she is verksvag. So she is weak of contractions would be like the correct translation, and that is also like just
the language. The language is full of that. I mean, your labor needs to be managed. You're not allowed. I'm drawing a blank on. There's all these terms that we use to disempower women. To make them think that they are not the one in control of their pregnancy and their birth. And again, it's done on purpose. It's absolutely done on purpose. From the moment you get into the hospital, you are treated as if you were sick. Because who goes to hospitals? Sick people.
Yeah.
And where do sick people go when they're in the hospital? In bed. So if you've ever been to a labor room in any hospital, what's the center of the room?
The bed.
Bed. If you've ever been to a home birth, how often do you find a woman in bed? Almost never. She might be leaning on the bed. She might be kneeling on the bed, but she's usually in the bathroom, in the shower, squatting in the toilet, holding on her husband in the kitchen, pacing, walking. She's not in the bed, but the hospital sees the bed as the center of the room, because that's how they see sick people are in bed, and that's where pregnant labor goes. Again, it's the whole mentality. They make you go into a bathroom and pee in a cup and change into a hospital gown. This is what you do before you're going to have knee surgery. Why am I peeing in a cup, and why am I going to the hospital? I'm putting on a hospital gown. Why am I getting blood drawn? Why am I getting an IV? Why do I need to sign consent forms and get a wristband? Oh, because it's a hospital. But you know what? When I go to a home birth, I don't do any of those things. We don't interrupt the woman to have her sign consent forms. We don't draw her blood. We don't give her an IV. We don't make her change into a hospital gown or a gown. She wears whatever she wants or nothing at all. That's her choice. And somehow these women and babies have births, like babies come out fine, and they didn't have labs. How did you have a baby without having your labs? I'm getting sarcastic now. I'm sorry. Um,
Yeah.
but again, the hospital does all these things because they're disempowering, and they generate revenue, by the way. Pretty much everything I just talked about generates revenue for the hospital. IVs, labs, hospital gowns, they can bill for all that. You know, they can't bill for any of those things if they don't do them. Do I think that that's the only reason? No, but I think that that's a reason why they're not changing. But they don't need any of those things for most women. And we, as physicians and nurses, we train to know when we need them and when we don't. And we come out of our training and then we're told by administrative people and risk management lawyers what we're supposed to do and how we're supposed to do it. That's why I think a lot of my colleagues are unhappy. They went into medicine hoping they'd be captain of their ship. And then they end up being the deck swab, the person that's, swabbing the deck and getting flogged for disrespect. That's what happens, and I think that makes people obviously very unhappy.
So
because we should be able to individualize our care, but the system doesn't want you to do that. So women, you need to demand it. You need to demand your care be individualized. You may not want the same birth that your sister had or your best friend had. That may not be for you. You may want to come in the minute you start having contractions and get an epidural or nitrous because you don't want to feel any discomfort. And if you've been informed of the benefits and the risks of those interventions and you choose them, that's your choice. But be sure you have all the information, because the hospital's going to want to sell you an epidural. They're going to want to tell you, oh, you don't want to be uncomfortable, you don't want to have that. But they don't tell you the downsides of an epidural, which are legion. There are multiple downsides to getting an epidural. We're not going to go into that today. That would be another podcast. So we can talk about some of the medical interventions specifics. But don't be a fool to think that the hospitals, everything they're doing is so great, because if everything was doing so great, then how come their outcomes aren't so great? They do not have your best interest at heart. And again, I'm not speaking about the individual. The individual is just basically a hamster in a wheel. The system does not have your best interest at heart. If they did, they would let you make your own decisions. They would let you decide and let you take the consequences of your own decisions. But they're not going to do that. They're going to skew the counseling to get you to do what they want you to do. And what they want you to do is not leading to better outcomes. So it's time to wake up. Let's return to the sanctity and the sovereignty that belongs to each pregnant woman, and take responsibility, and don't surrender your autonomy. Don't abdicate your responsibility. Make this that most joyous event of your life. And if it doesn't go the way you want, at least you know that the interventions were necessary, and you won't have that regret 2 years, 5 years, 10 years down the road, when you suddenly wake up and realize, oh my God, I didn't really need all that stuff done. And I deprived my baby of its birthright, and me of my rite of passage, which is as a woman to give birth to my children and nurture them, and leave nature alone, and leave the cord alone, leave the placenta alone, have the baby crawl on your belly, get to the breast, be on your breast, skin to skin for hours after birth. No reason for the baby to go anywhere else. Baby only needs its mom. Sorry, dads. But yeah, I mean, but I would just want to say to the men, if there's any men listening to this podcast, I don't know how many men actually listen to birth podcasts, but those of you who support your woman, those of you who are there for women when she's in labor, those of you who help catch your baby or even just witness that, I've said this over and over again for years. Those men are going to be better husbands, better fathers, more likely to stay in the marriage, more likely to have the respect of their woman. Men, one of their greatest needs is to be respected by their spouse. And in the hospital system, men are often disempowered. They're put off to the side. Women are often abused, whether overtly or covertly. And they often are hoping that their protector, their man, is going to step in. And if he doesn't, she will, at some point, subconsciously or consciously, recognize that he wasn't there for me. So the men need to be as educated about birth process and about our bodies, and so they don't giggle and say the stupid things that teenage boys say about teenage girls, and then that carries forward into adulthood. Uh, it's just a marvelous thing. I've been blessed for over 42 years, 43 years now of being in this business. Um, and I've had the opportunity, I shouldn't even call it a business. I should call it a profession, or I should call it a witnessing to a miracle over and over again. It doesn't always come out great. There's no perfect answer. Uh, Again, if hospital births were the answer, then we'd have good outcomes, and they're not, and the outcomes are worse. So there's no guarantee of an outcome whether you have a home birth or a hospital birth. But taking sovereignty over yourself, it gives you a lifetime of it just changes you. It's I can't think of the right word. You metamorphosize into something more powerful than you ever thought you could possibly be by taking responsibility for yourself during this period of time. And I'm starting to say things over and over again, so we'll just probably end it there.
Yeah, but I love how you phrase things, and those are all great reminders for the women listening and the men listening, because I think that's such a great point of view, that the men listening are also so important in the birthing space, to serve the role as a protector and provider in the room as well. There is one question that I always ask my guests at the end of the conversation, and that is, if you were to reach that's the trickiest one maybe, but if you were to reach the whole world for 30 seconds, what is something you would like to maybe say to them or do with them if you got that opportunity?
I would say that our immune system and our immune health begins in the womb. And we are seeing a wave of chronic disease and autoimmune disorders. Long before COVID, we've seen just rising rates of allergies and autoimmune disorders and autism and neurodiversity that is not necessarily desirable. And I think a lot of it, I mean, there are many factors, but a lot of it has to do with the way we're born. So I would just tell people that how we birth matters. It is not just a thing that you have to endure and go into the hospital and come out, with the baby. When we were generations ago, children saw their siblings being born, and they saw their grandparents pass away. And in the generations that have followed, we've sterilized birth and death. We've taken it away from our everyday knowledge. And in doing so, we've probably destroyed humanity, because, mom comes home with this new package and kids have no idea where it came from. And grandma died alone in a nursing home, and we didn't get to say goodbye. Grandma should be in our home, and mom should give birth in our home, except on those rare occasions where they need hospitalization. And if we did that, if we return to humanity, and if we realize that our immune systems and our health begin inside the womb, and how we are born matters, I think we could change the world. I think if women had good experiences in birth, they would be more powerful, and I think that we would see a change, which we desperately need. As we started our discussion today, I told you I feel there's something really off in the world. I don't know that it would cure the world, but I think that women regaining power over their bodies and understanding what I've said over the last hour and a half, we could change things for the better. Would we solve all the world's problems? Of course not, but we could change things for the better. I mean, in my country, much of the crime comes from the fact that there are no fathers in the home. And there's cultural reasons for that as well, but also part of it is the fact that fathers are not considered important in the medicalized birth model and all those other things. So for fathers and mothers, understand how important this thing is, and we can make the world a better place.
Yeah. Thank you, Stu, for this hour and a half. And for the listeners who would like to get in touch with you or dive deeper into your work, where can they find you and your work?
Everything I do is Birthing Instincts. So Instagram, I'm at Birthing Instincts. My website is birthinginstincts.com. Podcast is Birthing Instincts. And the podcast website is birthinginstinctspodcast.com. We have a Patreon group, Blyss, my co-host, and I. We have over 2,000 members. We have a really sweet community. We have different tiers. You can join for free and get some of the basic stuff. And that you can find at the Birthing Instincts podcast website. And then if you want to pay more, you can get tiers. We have monthly peer review. We have monthly Q&A where people can come and ask questions. We do special added content, behind the scenes things that are on our Patreon. And then I teach breech and twin birthing skills. I go around the world. I'd love to come to Sweden at some point. I teach a 2-day seminar on these skills, which are so necessary. It's very hard for me to get physicians to come to it. I would really love to have them, because even if a doctor is in a setting where he's not going to be allowed to do breech delivery, every now and then a woman's going to walk in with a breech baby's butt or feet sticking out of the vagina, and they're not going to know what to do, and it's going to end up in the cesarean disaster. So they ought to know these skills. It makes you feel like an obstetrician to know them. I don't do Twitter or TikTok. I know I've had my assistant encourage me to do those things. I just don't have the bandwidth to do them. So find me on Instagram and check out the website. I've written some papers on home birthing with breeches, home birthing with twins. You can find those. They're all linked on the website. And then I wrote a book years ago, which is a little bit out of date because it was before I was doing home birthing. It's called Fearless Pregnancy, Wisdom and Reassurance from a Doctor, a Midwife, and a Mom. And, some of the stuff is still very, very current, and a couple of the chapters are obsolete, like the genetics chapter has changed dramatically in the last 20 years. But it's still a good read for people looking for alternative books that are not fear-based. Many of the most commonly read pregnancy books are very, very fear-based. They tell you what to expect, but then they tell you that if you get what I drift where I'm going with the expect thing. That book is a very fear-based book, and they always tell you to call your doctor because it might be this, it might be that. And again, pregnancy is not an illness. So find me there, follow me, support me in that way. I just would love you to share this information with your friends so that we cause ripple effects. That's why doing your podcast, Madeline, is so great, because there will people that will listen and will tune it out. And there will people that will listen that will then share it with other people who will listen. And if you and I can affect one family at a time and change the course of their family's history, then that's a good thing, because downstream, those children will remember that they were born at home and or that they didn't fear pregnancy, and that will then propagate itself out.
Yes. Oh, that's beautiful. Thank you so much for your time, your wisdom, and everything you're blessing the world with. So thank you.
Thank you. You're welcome.